So I'm going to teach you today about atrial fibrillation. Welcome everyone. Hope you've had a good Christmas. Happy New Year. Before we get on to the talk about atrial fibrillation, I'll just give a moment for if anybody else wants to join us, and we'll go through an ECG. If you're interested in learning more about ECGs, I've got quite a few on the YouTube channel that I've sent you a link to. I've done a series on ischemia, and there are about 13 ECGs that cover lots of different types of ischemia. So have a look through those, and if you find them useful, let me know. And if enough people like them, I'll make a series on other conditions. But this one isn't one of the ones up there because it's not ischemia. But what does this ECG show? Does anybody want to have a look at this ECG and tell me what it shows? So I can see the chat. If you want to put answers in the chat, or you want to unmute yourself and speak, either's fine by me. Can anybody say anything about this ECG? There are no wrong answers. What's the heart rate here? Rate is relatively slow. Do you know how to assess the heart rate on a 12-lead ECG? You can count the number of small squares between the QRS complexes and then do 300 divided by that number. Or you can count the number of complexes on a 12-lead ECG, which is about a 10-second recording, and multiply by 6. So if you have 1, 2, 3, 4, 5, 6, that's a heart rate of 36. So it's a slow heart rate. Can you tell me what's causing the slow heart rate here? What I want you to point out for me is that the underlying rhythm here, we can't see any organized P waves, and it's a bit irregular. So this is atrial fibrillation. And I also want you to tell me that this is bundle branch block, and this is left bundle branch block. Now, with a rate of 36, we'd be worried about a form of heart block, such as complete heart block. So how can we tell if this is a slow heart rhythm because of slow AF? And how can we tell if this is complete heart block? Yeah, sure. Yes, fine. So the answer to that is atrial fibrillation always gives rise to an irregular heart rhythm. So if you have AF and it's conducted through the AV node, you will always end up with an irregular ventricular rhythm, because AF is a chaotic electrical signal in the atrium, and that chaos is never going to end up with a nice regular rhythm. So as soon as you have a regular ventricular rhythm in atrial fibrillation, you know that you have a AV block. And so complete heart block in AF gives a regular escape rhythm, and that's what you're seeing here. So this patient might not be symptomatic, or they might be keeling over and feeling terrible. You don't know, but if you see them and they're asymptomatic and they have this heart rhythm, you can't just say, oh, it's slow AF, I'm going to reduce their medications. They're at risk of sudden death because of their complete heart block and need an immediate admission. So an important one not to miss. So atrial fibrillation and a regular underlying rhythm that's bradycardic, think heart block. Great. So let's move on and talk about atrial fibrillation for the non-specialist. So I've got 4 or so patients to give you as examples, and please, please engage in the talk. Please unmute yourselves and speak, or put comments in the chat, whatever works. I'm very happy to hear from you. So our first patient, I've called Mrs. Fractured Neck of Femur, and she's an 80-year-old lady. Her background is she's normally able to walk about 200 meters, but unfortunately she had a fall and broke her hip and had surgery yesterday. She's got a BMI of 25, a history of high blood pressure, but not much else. And she's reasonably well, although relatively low exercise tolerance 80-year-old lady. And she's developed acute shortness of breath and palpitations and chest tightness, and has a blood pressure of 150 over 80, SATs 95% on air, and this is her 12-lead ECG. And I hope that you all agree with me that this ECG shows fast atrial fibrillation. So we've got an irregular rhythm, and it's tachycardia. So she's in fast atrial fibrillation. So what are you going to, what's causing this? Why has she got fast atrial fibrillation? Yeah, maybe she's had a PE, very good. So she's at high risk of a pulmonary embolism. That could very much explain the tachycardia and the hypoxia. Any other suggestions? Yes, infection. So high risk for something like a chest infection post-surgery, a UTI. So she could be septic, and that be causing the fast AF. Any other possible reasons? So she could have the stress of surgery has put her into new atrial fibrillation. And if she's normally in sinus rhythm and she goes into AF, she could be tachycardic because she's in AF. The rate of somebody's heart in AF is very, very variable. But it does very much tend to be, as you get older and your AV node becomes less good at conducting, or basically a bit deafer to the atrium, then you tend to go slower when you go into atrial fibrillation. So when a 90-year-old goes into AF, they will tend to go slower than an 80-year-old or a 70-year-old. When a 20-year-old goes into AF, they tend to go very fast. But we don't know. There's a great deal of variability, and it might be that simply she's in new atrial fibrillation put in there because of the stress of the fall and the fracture and the surgery, and she's tachycardic because she's in fast AF for the first time. But there are lots of other things that could have caused the atrial fibrillation, or she could have been in atrial fibrillation all along. So she might have been in AF the last 10 years. Now, she's been in AF the last 10 years and she's been rate controlled the last 10 years, and now suddenly she's tachycardic. Then the atrial fibrillation is absolutely nothing to do with why she's tachycardic. It is that she might have, as you say, PE, infection. I've suggested some other things here, anemia and bleeding and heart failure would be alternatives. So we want to know, is the atrial fibrillation old or new? And we want to have an open mind about this rather than phoning up the cardiology registrar to say, how do we treat the AF? We really want to treat the patient, and we want to treat the reason for them having fast atrial fibrillation. So what would you propose we do to treat this patient? Yeah, so I'm not going to go over all of this in lots of detail because I've got some other examples. So we could do lots of further tests to try and establish why this patient is unwell with atrial fibrillation. And a chest x-ray would be an excellent suggestion for that. And we could do some blood tests and we could look for a PE, etc. But so the answer really, I think you're trying to give me there is you want to treat the underlying cause, which is absolutely right. And depending upon what the underlying cause is, we could think about giving her a beta blocker, and we should certainly think about anticoagulation. Now, in terms of giving a beta blocker, if she's tachycardic because she's really poorly and she's trying to maintain her cardiac output by the tachycardia, then actually you'll make her more unwell. So this rate on this ECG, it's about 140-ish. It's not desperately fast. It's probably not going to make her hemodynamics that much better or any better to slow her rate down. But if she's really poorly and she's desperately trying to keep the body's demands for oxygen and etc. supplied by the heart, and the only way of doing that is to make herself tachycardic, and you then artificially slow her down, that's when you put somebody into cardiogenic shock. So if, for example, she had developed new heart failure because of all the fluid they were giving her in surgery, and you say, oh my goodness, the fast AF that she's had all along at rate of 80 is now 140. We must slow that down with a beta blocker to make her better. Actually, you will put her into cardiogenic shock if you give her a beta blocker because she's in pulmonary edema from all the fluid and she's trying to maintain cardiac output in the face of that pulmonary edema by having a tachycardia. Does that make sense? So we really need to treat the underlying cause, and it's not necessarily this relatively okay rate that's causing the problem. We all know about anticoagulation, so we anticoagulate based on the CHA2DS2-VASc score, and we weigh up the risk of bleeding using the HAS-BLED score, although you might tell me, oh no, it's now the ORBIT score. The latest NICE guidance has suggested we use the ORBIT bleeding risk score. I'm not particularly excited about using one or the other. Actually, if you look at the evidence base for it, it's pretty rubbish. If we look at the advantages of the rocket, and if we look at the advantages of orbit over HAS-BLED, the C index is only 0.67 versus 0.64, so there's no significant difference really between the two. It seems a little bit much for everybody to learn a new system, but if you want to start learning what bleeding risk calculator to use, then learn the orbit one because it's possibly marginally better, arguably. Interestingly, the CHA2DS2-VASc score is of relatively limited accuracy. It's the problem is it's the best thing that we have, and some of the scores within this weigh more heavily than others. So, for example, if you're diabetic, that is substantially more of a risk factor than being a woman, but they both score equally. It's important to learn the different components of the CHA2DS2-VASc score because that's something that you will come up against all the time. And I don't tend to calculate an orbit score for every single patient that I see with atrial fibrillation. It's only where I'm actually having some pause for thought. You might want to. But it's usually fairly straightforward. If somebody has a risk of a high CHA2DS2-VASc score and a high orbit score or HAS-BLED score, what we tend to do is subtract one from the other. So if your CHA2DS2-VASc score is 5 and your HAS-BLED score is 5 or 4, you would end up anticoagulating. But if your HAS-BLED score was 6, you wouldn't. Whether you can really do that or not with the orbit, probably, but it's less established in that way. We sometimes deny patients anticoagulation because we say they're at risk of falls. That's a hard one because this study, for example, is based on the risk of bleeding if you are judged to be high risk of falls or low risk of falls, seeing absolutely no difference. But you only got anticoagulated if the doctors judged you to be okay to anticoagulate in the first place. So if they thought, my goodness, this person can't possibly get anticoagulation because they're falling and hitting their head every day, they would have never ended up in this observational study. So really good evidence that it's safe to anticoagulate isn't really there. But what we do have really strongly points towards, unless you really think somebody shouldn't be anticoagulated because of their very high risk of injury from falls, they should be anticoagulated. So falls is a relative contraindication. It's by no means an absolute contraindication, and your risk of stroke obviously substantially outweighs the risk of falls and injury due to falling on anticoagulation in the vast majority of people. Great, so let's move on to our patient number 2. So this patient is called Mrs. Atrial Fibrillation, and she's 55 years old. Now, imagine that you're seeing her in your GP surgery, or imagine that you're doing a cardiology clinic and you've had her referred in by your GP. Either way, it comes to the same thing. This lady's had recent onset atrial fibrillation, and what are the symptoms you're going to ask her for? What questions are you going to ask her to establish symptoms from atrial fibrillation? Dizziness, maybe. Dizziness, palpitations, and shortness of breath, yes. Patients don't usually get lightheaded or dizzy due to atrial fibrillation. Patients don't have blackouts due to atrial fibrillation itself. But yes, palpitations and shortness of breath, very good. Anything else? The big one that patients complain about is fatigue. But the other thing I would want you to ask about is are the episodes occurring in a precise episodic manner? Does the patient have 2 hours where they're aware their heart's jumping around and misbehaving, and then it goes back to normal again? Because that can point you towards, is it likely to be paroxysmal or persistent? And sometimes patients don't get anything by way of palpitations, but get breathlessness that is quite episodic. And it could be that they're going in and out of atrial fibrillation, causing their symptoms of breathlessness. Good. So those are the atrial fibrillation questions. Are there any other key things that you think about when you have got a patient with atrial fibrillation? So not related to the AF itself or the symptoms from AF, but are there any other key questions about past medical history, social history that you would want to be asking the patient? Yeah, thyroid symptoms. If you've got hyper or hypothyroidism, that will certainly cause you atrial fibrillation. So that's a good suggestion. We should check thyroid function in all of our patients with AF. So I would worry slightly less about that. I know obviously it's nice to do good clinical work, but we should check thyroid in everybody with atrial fibrillation anyway. History of ischemic heart disease, yeah, that won't particularly move us one way or the other. Substance abuse, yeah, that's true. Alcohol history, that's a really good one. So alcohol history is really important in atrial fibrillation. Good. Anything else? So obesity is another massive factor in atrial fibrillation occurring and in successfully getting somebody out of atrial fibrillation. We've mentioned about alcohol. And you also want to ask about things which would put her at risk of bleeding and stroke. Those are the sort of the big ones. You want to do an ECG, and this, for example, might be a ECG which shows rate-controlled atrial fibrillation. So some patients need lots of treatment to achieve rate control. This patient isn't requiring any. That's maybe slightly surprising at 55. So how are we going to manage this patient with atrial fibrillation? Well, I'm going to just make this boil down to 5 points. Number one, we want to think about anticoagulation. And we base that on Chad's-Vask and orbit, as we've just said. Anticoagulation is critical, very, very important to make an assessment of anticoagulation in every AF patient you see. Now, if her Chad's-Vask score was 0, which it can't be because she's a woman, unless she's non-binary, that means that she needs, we need to consider anticoagulation. So Chad's-Vask of 0 or 1, we probably wouldn't think about anticoagulation, although if that 1 was for diabetes, we might. Make sure you consider that. Next, we need to consider rate control, and the precise rate is a hard one. It depends a bit on symptoms and what makes the patient feel better, but a rate of around 90 or below is probably what I would aim for, and beta blocker is the first choice drug for that. The problem with digoxin in a young patient is that it works reasonably well at rest, but they exert themselves and the heart rate flies off because you're not blocking the adrenaline. So a beta blocker is really first line choice, and probably a rate limiting calcium channel blocker like diltiazem would be second line. So that's 1 and 2. Point 3 is consider doing an echocardiogram. Now, NICE guidance, the latest NICE guidance, doesn't really recommend an echo for everyone, and I suppose that's reasonable given that AF affects such a vast number of patients. But the thing is, why have you got the AF? You know, if you're 20 and you're fit and healthy and you've been binge drinking alcohol all weekend and then you go into AF on the Monday, then, you know, it was the alcohol that did it. Do you really need an echocardiogram? But my counter to that is, well, why is that 20-year-old who's binge drunk got into AF and the next person down the line who's been misbehaving hasn't gone into AF? Maybe the alcohol's causing cardiomyopathy. So it's even in that sort of a patient, maybe we should be doing an echo. If you have somebody who's 60 and has gone into atrial fibrillation, then maybe they've got an ASD that you won't ever hear with a stethoscope, and if you don't diagnose it and fix it, then they'll do badly that they could otherwise be sorted out. They could have a valve problem. How good are your ears at detecting mitral regurgitation, for example? So I do tend to think all patients with AF should have an echocardiogram at diagnosis so that you can look at why it's happened, even if there's an obvious cause, because often you've got underlying substrate for atrial fibrillation. There's a reason that person, that chest infection has caused atrial fibrillation. It's because they've got an underlying tendency rather than it purely being the infection. And then you need a personalized package of care for the patient. And that means addressing risk factors for atrial fibrillation. It means deciding, are we going to get them out of the atrial fibrillation or not? And if they are young, and particularly if the AF has been caused by something like an infection or surgery or stress, it may well be worth having a go at putting them back into a normal rhythm, and hopefully that sticks and they may feel better for it. But for most patients, the decision to get them out of atrial fibrillation is entirely based on symptoms. So if you've anticoagulated and rate controlled them and they're free of symptoms, then that probably trying to get them out of it isn't going to really help a great deal. But having a personalized package of care for them, so addressing alcohol, addressing obesity, getting them to do regular exercise, controlling their blood pressure. If we want to get them out of atrial fibrillation, that's incredibly important. And these patients, they have double the age-matched mortality rates. Atrial fibrillation confers a substantially higher mortality rate. And I suspect that's far more to do with the unhealthiness causing the atrial fibrillation than the atrial fibrillation being directly responsible for the higher mortality, but address their risk factors. And then if they are still symptomatic, or if they are particularly biologically young, they need specialist input, so you could refer them to cardiologist. But trying to get somebody out of atrial fibrillation if they're asymptomatic is something that we don't have any evidence it really helps. So symptomatic patients, particularly young patients, we would want to be involved with them. But if they have no symptoms, particularly if they're elderly and they're anticoagulated and rate controlled, then they don't need any further input. We can do AF ablations on top of everything you can do. I suppose, I don't know how often you request cardioversions if you're not doing cardiology, but the main thing we do about AF that nobody else does is we do AF ablations. But these are not straightforward, simple procedures, and they do carry a substantial risk. So while they are fantastically beneficial and important for symptomatic patients who really don't get on with their atrial fibrillation, they're not something that should be done just because we can do it and it doesn't cost the patient any money. And this is based on obviously the latest NICE guidance, which is very much in line with what I've just said. So referral for specialist management, you should only need to do it if you're failing to control symptoms. Why do we take this approach? Well, back in 2002, there was the AFFIRM trial, which showed that atrial fibrillation was as well prognostically as good if we simply rate controlled versus if we tried to control their heart rhythm. So that showed us even 20 years ago that we didn't benefit from restoring sinus rhythm. There are nuances to this, and people would argue one way or the other about it. But the bottom line is that there isn't really any evidence being in sinus rhythm is better. If you were 20 and you were in AF for the rest of your life, then I would be queasy about that. But if you're 60 and you have lots of comorbidities that have caused it, I wouldn't be trying to chase sinus rhythm because it will be an awful lot of perspiration for the patient for little benefit. These are a couple of other interesting papers. There's this is a wonderful little study from Australia. It's in the New England Journal and it only enrolled 140 patients. I wish I had come up with this. They looked at patients who are drinking about equivalent of 14 units of alcohol a week, so not a great deal, but clearly not none either. And they found that abstinence reduced recurrence of atrial fibrillation from 73% to 53%. So cutting out alcohol had a big reduction in recurrence of atrial fibrillation. You might say, well, 20% reduction in recurrence, well, I'd rather have my alcohol. But if you offer them an AF ablation, that will achieve about the same level of reduction in recurrence of atrial fibrillation. And that is a major undertaking in terms of procedural time and risk. So, so cutting out alcohol, if you're serious about being out of atrial fibrillation, should be an important consideration, along with exercise and losing weight. Patient 3. This patient is Mr. Exercise, and he's 52. And he's got sudden onset of fast palpitations which occur during exercise. They last 1 hour. He's very specific about this. They're very symptomatic. He's really, really aware of them. And he really likes to cycle, and he does 200 miles a week. And he likes to be able to beat the young whippersnappers in his cycling group. So he pushes himself really hard so that he can come out on top. He doesn't have any other risk factors for atrial fibrillation. Any comments about that, the fact that he gets sudden onset fast palpitations occurring during exercise, which make him very symptomatic? Well, any exercise-induced palpitations should be an immediate red flag for you. That should worry you because patients could get VT during exercise, which obviously could explain his symptoms, not usually lasting for an hour, but all things are possible. So while in this case it turns out to be atrial fibrillation, well, the moment you hear exercise-induced palpitations, this is an urgent, we need to find out what's going on with this chap. So he's going into fast atrial fibrillation, and this is a fairly fast ECG rate of 180. He might even be going at more like 200 if he's gone into this while he's exercising. And it's no wonder that he will feel unwell with this if he's working hard on his bike and suddenly goes into this arrhythmia. So what are your options, given that he's presenting to your admissions unit with this ECG in the fast atrial fibrillation, and it's stayed fast for the first time. He was cycling when it came on. What are you going to do for him? Going to give him a bit of beta blocker? If he's unstable, you could cardiovert him, but he's not. He's symptomatic, but he's not unstable. So he's presenting very clearly within 48 hours. So that means he can be cardioverted without anticoagulation. So you might give him a dose of heparin, but you don't need to put him on anticoagulation depending upon his CHA2DS2-VASc score. Vast majority of people like this will spontaneously cardiovert. So you could give him a bit of beta blocker, slow him down, and expect next day for him to have cardioverted, and then you can electrically cardiovert him if he hasn't. I would be very surprised if he doesn't cardiovert himself. So while you could give him some electricity, there's probably no need, and I wouldn't particularly give him IV amiodarone, which I sometimes see, because you're going to have really nasty side effects from even a single dose of IV amiodarone. You can develop a lung fibrosis that comes on late, or you can get it with first dose. So I wouldn't particularly give that. We could give him some IV flecainide, and there are newer drugs which are coming available for cardioversion, but just time will cardiovert him. And what do we do now that we've, assuming next day he's back in sinus rhythm, what do we do to try to control his symptoms? Yeah, we could give him a beta blocker, but I suspect, given how much cycling he's doing, that he'll be going quite slowly in sinus rhythm already. And he's a keen cyclist and won't like the fact that he can't quite push himself as hard because of the beta blocker. But we could certainly do that, and we could do an echocardiogram, check that his heart's otherwise normal, and we could then give him some flecainide. Flecanide's very bad if you've got an abnormal heart. It increases your risk of life-threatening ventricular tachycardias. It was famously given in the CAST study to patients with ectopics after myocardial infarctions, and it was great at getting rid of the ventricular ectopy, but it caused them to die suddenly. So it went out of favor, but if you've got a normal structural heart, it's good for atrial fibrillation. So we could try that, but I suspect that we will struggle a bit. And he's keen to carry on cycling. Now, it's a balance always. The amount that he's pushing himself is why this has happened in him. Racehorses get atrial fibrillation, and cyclists are particularly bad for pushing themselves really hard. They sort of achieve a pitch of performance where they're really balancing on anaerobic, aerobic activities, and they stay at that sort of pitch of working really hard for long periods of time, and they tend to put themselves into atrial fibrillation. So I would recommend that he reduces the amount that he does, because if he's still driving himself back into atrial fibrillation, we're going to struggle to keep him in sinus rhythm. But if medications aren't working, this is the kind of person that I would be thinking is highly likely to end up needing an AF ablation. And he's the kind of person who will also do well with an AF ablation, because he doesn't have lots of the risk factors for making him go back into atrial fibrillation. So that's an example of where AF ablation can be really, really useful and be essential really for symptomatic relief for the patient. So now we're on to patient number 4. And Mr. 4 is Mr. Easy Rider. And he's a 65-year-old gentleman. And he's had multiple admissions with palpitations, which are sudden in onset, and they last until he attends hospital for cardioversion. And his ECG looks like this. Can anybody tell me about this ECG? So is this atrial fibrillation? Can you see if you look along the rhythm strip, we have a sawtooth pattern? And the rate here is pretty regular. There are some bits which are a little bit suspect, but it's pretty regular and it's around 150. And that suggests atrial flutter. And this is another example. So you've got a sawtooth baseline. As soon as your heart slows down a bit, it often becomes a bit easier. Now, it can be quite hard. Often you do get a coarse appearance in V1, so you can confuse yourself. But what you're looking for is a very much the same morphology of each of the flutter waves. So if this looks different to this, then that would be against atrial flutter. It would be coarse atrial fibrillation. But these are reasonably consistent flutter waves coming all the way through, and you've got a regular ventricular rhythm. Now, atrial flutter and atrial fibrillation sound very, very similar, and they are completely different in some ways and very similar in others. So let me tell you what they are. Normally, you get your natural pacemaker in the sinoatrial node sending a signal through the atrium telling the atria to contract. And then that signal can't go through just anywhere. It can only go through the AV node, which holds things up to allow time for the atria to contract and fill the ventricles. And then once it's allowed about 200 milliseconds, maybe slightly less than that, maybe 120 to 200 milliseconds, it will conduct through to the ventricle and the ventricles will contract. And so that gives us our nice normal sinus beat. In atrial fibrillation, on the other hand, there is a chaos of electrical activity swirling around in the atria, and that probably is going at a rate of about 300, maybe 300 to 500 electrical activations of the atrium a minute. And that swirling electrical activity, that high speed, means that the atrium doesn't actually do anything much, because it's too fast for it to contract, and so you get risks of atrial fibrillation. And that chaos of electrical activity, sometimes it goes louder towards the AV node, sometimes quieter, and so when it hears the louder ones and it conducts down to the ventricle. So that's atrial fibrillation, this chaotic rhythm that is very hard to fix, but is often relatively easy to rate control and we anticoagulate. Atrial flutter, on the other hand, is a circuit going round and round and round in the right atrium. So round and round and round in the right atrium. And it goes round at a rate of 300 times a minute. And that's why this very organized circuit gives rise to a very organized appearance on the 12-lead ECG, this flutter wave. And you can have, every time it goes round, it conducts the ventricle. That will give you a rate of 300, not very common. Sometimes happens if you give patients flecainide. But it will very often, happily, the AV node in most people will conduct at a rate of 150. So you often end up with a heart rate of 150 and 2-to-1 block with this flutter circuit. But it could be 3-to-1 or 4-to-1, and on an individual ECG, you might have bits that are 2-to-1 and bits that are 3-to-1 and bits that are 5-to-1. So you can get an irregular appearance, but you have to have set RR intervals, which are a ratio of flutter circuit to the RR interval. So it's a very organized circuit within the atrium, and it gives rise to an organized ECG. Now, because this circuit is going fast and it's not properly organized, it's not leading to proper atrial contraction because it's so fast, you're needing anticoagulation. And in order to deafen the AV node to this tachycardia, we can give the same sort of drugs, beta blockers, calcium channel blockers, digoxin, but it's much harder with this organized circuit, and particularly with the AV node happy to go at a rate of 150, it's much harder to rate control atrial flutter. So we do tend to struggle more with pills. However, it's very easy to fix because while atrial fibrillation is incurable, it can be temporarily prevented or stopped by doing an AF ablation, but it can't be cured. Atrial flutter, on the other hand, if you burn a line across this circuit, and the chosen point is here, the cava tricuspid isthmus, because that's the narrowest point. If you burn a line across there, then the patient can no longer form the circuit, and so their atrial fibrillation, their atrial flutter is cured and gone. So you can easily fix atrial flutter with an EP study and ablation. Patients are often then left with atrial fibrillation because the two do often go hand in hand, but the atrial flutter might be really hard to rate control. The atrial fibrillation is suddenly a much more straightforward proposition. But that can confuse people endlessly. They went to have their atrial flutter fixed and they've been left with atrial fibrillation. Why did they have such an unsuccessful procedure? Of course, that's a it's a confusion rather than actually being the case. So just to summarize, atrial flutter, an organized circuit. Atrial fibrillation is chaotic. Rate control is difficult in atrial flutter and usually straightforward in fibrillation. Both need to be anticoagulated. Both can be electrically cardioverted. It tends to use less electricity to cardiovert atrial flutter, but don't worry too much about that. But the other big difference is we can usually, for atrial flutter, there's nothing's absolute, and there are some more complex forms of it, particularly that happen after AF ablation. But normal atrial flutter is relatively simple to cure and fix with ablation, and it's more likely, because rate control can be difficult, that we'll have to consider it. Whereas for AF, it can be incredibly important and valuable to very symptomatic patients, but we need the full package of a lifestyle adjustment in order to be successful in dealing with our atrial fibrillation. And the ablation is never permanent. It's only a temporary benefit, which might be a very important temporary benefit for some patients. Finally, we have a bonus patient, which is Mr. Easy Rider's identical twin. And he's completely asymptomatic, but he's heard about his brother and the trouble that he's been getting. And so he gets a method of doing an ECG, and he is told by his device that he needs to go and see a doctor. So that doctor is you, and he shows you this. What do you do about this? So this isn't a medical device. This is his, for example, his Apple Watch, which is very cleverly doing an ECG and telling him that he's got atrial fibrillation. Do you agree with it? Are we going to anticoagulate this gentleman based on this? So we could do a formal ECG, but what if he only has 5 minutes of atrial fibrillation once a year and he's caught it with this Apple Watch and you'll never capture it with your 24-hour monitor? Are you satisfied this is AF? So I would put it to you that it's a very irregular heart rhythm, and that it's hard to see this being due to anything other than atrial fibrillation. Sure, you could have atrial ectopics, but it would be very unusual to have it occurring quite like this. You can see that the morphology of the QRS is broadly similar all the way through, but look how much the T waves change. There's a lot of filtering going on this to give us what looks like a nice ECG, but I'm sure the raw signal didn't look nice at all, and some very clever people have turned it into something that makes me happy. But not knowing quite what they've done to it and quite how much filtering has been required does make me queasy as to what actually is going on underneath this. But that filtering shouldn't make the QRSs irregular. It might affect the appearance of the T waves in all sorts of ways, but it wouldn't particularly give us an irregular QRS signal. And so this irregular signal, I think, is fairly definitive that this is atrial fibrillation. So I would be satisfied with that. But the problem is, do these patients benefit from anticoagulation? We know that patients with AF benefit from anticoagulation. I said that earlier, but those are patients who present with symptomatic AF, or they're found to have it for another reason that they're attending hospital. Patients who are truly asymptomatic, what are their risks? You could look at the CHA2DS2-VASc risk, but how long is the AF lasting for? This is a study called the LOOP study, presented last year, and this took really high risk patients who had more than 6 minutes of atrial fibrillation. So just 6 minutes of atrial fibrillation was enough to get you anticoagulated permanently going forwards. And they studied about 6,000 patients, and they found that it didn't make any difference to your risk if you went onto anticoagulation. And these are high CHA2DS2-VASc score patients. But how many of them had 6 minutes of AF? You know, if you have AF lasting for days at a time, I could certainly see the need for anticoagulation. It's much less well understood when you're having shorter periods. And the problem is that we've always assumed that if you're having a short period now, you're having longer periods that we can't capture. But if you've got a watch and you're monitoring things all the time, then that argument doesn't really hold anymore, and maybe you are capturing the very short periods. So it's really quite hard to know what to do with this patient. The graphs here show you that you'd had no impact on all-cause mortality. And partly it may be that they chose too high a risk cohort, and these patients were having ischemic strokes rather than embolic strokes. But I think we really don't quite know what to do with these patients at the moment. If he was having multiple episodes lasting for hours at a time, I would be much more comfortable anticoagulating him. If that's a one-off and we've never seen anything like it before and his CHA2DS2-VASc score is 2, then I would be really struggling. And it's a discussion with the patient, and it's explaining the lack of evidence and explaining that there are risks of anticoagulation, there are risks of not anticoagulating. Brilliant. Well, thank you very much for listening. So just my summary of how we manage these patients. The most important thing is to anticoagulate patients who are presenting with AF based on the CHA2DS2-VASc and ORBIT or HAS-BLED scores. It's very important that we look at rate control. We consider the echocardiogram, and we look at the whole patient. We consider alcohol, obesity, exercise, blood pressure. Obstructive sleep apnea is another big one that I've not got on here, but obstructive sleep apnea often goes hand in hand with atrial fibrillation. And we can certainly think about cardioversion, but that tends to be for patients who've had an acute cause of their atrial fibrillation, or for biologically young patients, or for patients with ongoing symptoms, and it may not be worth the effort for the patient, not for us. We do what we're asked to do, but if it's going to mean multiple appointments, toxic drugs like amiodarone, then maybe they're better off just accepting the atrial fibrillation and getting on. Thank you very much for listening. Are there any questions at all?